Hello, and my name is Lois Freed. I am a facilitator, co-facilitator for ThyCa in the Northern California area, about 23 miles south of downtown San Francisco. And I am very happy to be facilitating our session today with Dr. Pearce. And I would like to introduce Dr. Elizabeth Pearce, who is an endocrinologist at Boston University School of Medicine in Boston, Massachusetts. Dr. Pearce received her undergraduate and medical degrees from Harvard University and a master's degree in epidemiology from the Boston University School of Public Health. She completed her residency in internal medicine at Beth Israel Deaconess Medical Center and her fellowship in endocrinology at Boston University. She is a professor of medicine at Boston University School of Medicine in the section of endocrinology, diabetes, and nutrition. She is a past president of the American Thyroid Association, and she also serves as the regional coordinator of North America for the Iodine Global Network. She recently co-chaired the American Thyroid Association's Thyroid in Pregnancy Guidelines Task Force. Her research interests include the sufficiency of dietary iodine in the US, thyroid function in pregnancy, the thyroid effects of environmental perchloric exposure, and the cardiovascular effects of subclinical thyroid dysfunction. Please join me in welcoming Dr. Elizabeth Pearce.
And I'm just going to get my slides up here. Can you see this okay?
Yes.
Perfect. Give me 1 second. There we go. So it's my pleasure to be with all of you today. This is a smaller group. This is kind of a niche area. So hopefully we'll have plenty of time at the end of my presentation to discuss and to answer questions. So what I'd like to start with is just an overview. I want to talk a little bit about how often pregnancy is a consideration in the care of thyroid cancer, or I guess vice versa. Talk a little bit about how we think differently about the diagnosis of thyroid cancer when it presents for the first time in pregnancy. And then any sort of management issues that are a little bit different when we're following patients with known differentiated thyroid cancer who become pregnant. There are a couple of important recent papers that I want to share looking at the effects of radioactive iodine on both pregnancy and on fertility. And then at the very end, I'll talk a little bit about medullary and anaplastic cancer in pregnancy. And unfortunately, there's not a whole lot of data to share for those cancers. So to start with, I actually see pregnant women clinically very often who present for the first time with new thyroid nodules during pregnancy. And I think that's probably true for a few reasons. One is that pregnancy is a time when there's so many changes in the body that women are very attuned to what's happening and maybe are just more inclined to notice the nodules that might have been there already. Often in pregnancy, women are interacting with the healthcare system more frequently. And I very often have patients come to see me because their obstetrician has happened to do a thyroid exam and a routine pregnancy visit and found the nodule for the first time. But it's also the case probably that nodules may show up or grow for the first time in pregnancy. And we know that from this small study that's on the slide here. These were 221 Chinese women who were followed with ultrasound from trimester 1, trimester 2, trimester 3 of pregnancy, and then looked at again after delivery. And what they found was in these women who had no nodules at baseline, that there was some increase in the size of the nodules over the course of pregnancy. They got smaller again after delivery. And that in some of these women, new nodules actually appeared during the course of gestation. So we don't know quite why that is. It may be that stimulation from the normal pregnancy hormones may cause a growth of nodules or the appearance of new nodules, and also the growth and appearance of new cancers, perhaps, in pregnancy. So we don't know quite how often this comes up in pregnant women. Somewhere between 3 and 21% of pregnant women probably have a nodule based on what's in the literature. And because thyroid cancer is a cancer more of women than of men, And because many women are diagnosed with thyroid cancer during their reproductive years, it's not that uncommon for women to be diagnosed with cancer and then go on later and become pregnant. So I don't have exact numbers for how frequently this occurs, but just based on what we know about the incidence of thyroid cancer by gender, by age, this sort of makes sense. So thinking about what happens when we diagnose a thyroid cancer for the first time in pregnancy. Most of the tools we use to diagnose cancer in pregnancy are the same as the tools we use to diagnose cancer outside the pregnancy setting, but there are a few places where things are a little different. So first of all, we use ultrasound in the same way in pregnancy that we do outside pregnancy to determine what nodules look like they're high risk based on sort of those high risk features and nodule size. We consider doing a biopsy of the nodules, and it's perfectly safe to do thyroid biopsy in pregnancy. There's no risk to mother or to fetus. So there's no reason why we can't do thyroid biopsy in pregnancy. But pregnancy is a time when, women often don't want to have increased anxiety. There's plenty to be anxious about already in pregnancy, lots of things you have to monitor. And some women really just don't want to be up at night waiting for biopsy results when they're pregnant, or they don't want to potentially find out that they have a thyroid cancer that we're going to need to wait to treat till after delivery. So some women really prefer just not to do this in pregnancy when nodules arise. And for the most part, that's probably safe to wait, as I'll show you in a moment. So we have some small studies, and most studies looking at thyroid cancer in pregnancy are small. I don't have a lot of big data sets to share with you today. But this is an old study and a small study, but still, I think, a really helpful study. So these are data from Ohio State University, published back in 1997. And here they followed 61 women with differentiated thyroid cancer, so papillary or follicular cancers. 14 of those women who were diagnosed during pregnancy opted to have thyroid surgery during pregnancy. And the other 47 women who were diagnosed with their thyroid cancers during pregnancy elected to wait until after the baby was born to have surgery. Typically, when surgery is needed in pregnancy, we prefer to do it in the second trimester. In the first trimester, there's always a concern that the anesthesia medications could cause birth defects. And in the third trimester, there's always a concern that we might promote premature labor. So generally, when surgery is done in pregnancy, the second trimester is safest. And probably generally, although it is safest in the second trimester, it is safer still outside the pregnancy setting. So having said that, these 61 women, 14 opted for surgery in pregnancy, 47 decided to wait. And what makes this study, I think, really important is that they had 22 years of follow-up after these cancers were diagnosed. And what they saw in these women with the thyroid cancers diagnosed in delivery is that whether or not they opted for surgery during pregnancy, the outcomes of their cancers were no different from 528 age-matched women who had thyroid cancers that were diagnosed outside the pregnancy setting. So I think fairly reassuring data. And we have another small study here looking at 19 women who were diagnosed with papillary thyroid cancer during early pregnancy. All of these women opted to wait to have thyroid surgery until after they delivered. And in fact, some of these women probably really didn't need surgery at all because the median tumor size here was quite small. It was less than a centimeter. So most of these women had low-risk cancers. On average, they waited about a year after the diagnosis of their cancers to undergo surgery. And they were followed over that course of that year with ultrasound, just making sure that there was no increase in tumor size or anything that would be concerning. And again, I think sort of reassuring data that there wasn't really any clinically meaningful change in tumor size over the year that women waited to have their surgeries, and no new lymph node metastases showed up. Now, we also have data from Japan, where for many, many years, they have had experience in patients with very low risk thyroid cancers, usually differentiated thyroid cancer that's less than a centimeter in size when it's discovered, in watching with close monitoring and without surgery. So in the course of this now many decade experience in Japan, they have published data for 50 women who together experienced 51 pregnancies while they were undergoing these active surveillance protocols for low-risk thyroid cancers. So they were evaluated with ultrasound before pregnancy, during pregnancy, after pregnancy. And what was found was that for most women, there was really no change in the size of their tumors over the course of pregnancy. For 4 of these women, so 8% of the group, there was an increase in tumor size of at least 3 millimeters. And that's an important number in these active surveillance protocols because that's the size increase that would typically trigger consideration of surgery. But again, only occurred in 8%, and none of these patients actually had any lymph node metastases that showed up over the course of pregnancy. Now, there are 2 studies from Italy that I want to show you as well. These are less reassuring data, and I'm never quite sure what to do with this information. So this is a study that was published back in 2010. They looked at 123 women in Italy, and they all had thyroid cancer, but they divided them into women, 47 women who were diagnosed with thyroid cancer at least 2 years after their last pregnancy. A small number, 15, who were diagnosed with cancer within 2 years of pregnancy. And then they compared them to 61 women who were the same age, but who had not been pregnant. And what they saw here was that at the bottom line, what's highlighted, that the women who were diagnosed during pregnancy or fairly close after pregnancy had a much higher risk that the tumor would persist than the women in the other groups. So it was 60% as opposed to 4% for the women whose pregnancies were at least 2 years after thyroid cancer, whose diagnoses were 2 years after pregnancy. I don't know why that is. It doesn't really fit with the other data I'm going to show you. And it's thought that maybe if these were women who had cancer surgery during pregnancy, that maybe the surgeons were a little bit less aggressive in the pregnancy setting. These are not great studies and they don't describe their methods very well. So it's not totally clear that this information is correct. But I would sort of pair that with this other study also from Italy, very similar design, but a few more women. So this is 340 pregnant women, and they sort of divided them up by timing the same way and saw sort of similar results, that there were higher risks, here not quite as high, for persistent tumor, 10% compared to 1.3% in those women who were diagnosed during or just after pregnancy compared to women whose diagnoses were further out from pregnancy. And again, they didn't really describe their methods very carefully here, so it's not really clear why. More reassuringly, the one study that's done something similar in the United States is this paper from Angela Liang and colleagues. And they looked at the thyroid cancer registry in California. They looked at women with differentiated thyroid cancer diagnoses between 1999 and 2012. So 300 women in this group had been pregnant, and they sort of defined recently pregnant at the time of diagnosis meant that they'd been pregnant up to 5 years before or 9 months after their thyroid cancer diagnosis. So they compared those 300 women to 900 women with thyroid cancers who hadn't had pregnancies. And they saw essentially not a lot of differences in the groups. So the tumor size at diagnosis was the same. The likelihood that thyroid cancer spread outside the thyroid was the same. The likelihood of distant metastases was actually a little bit lower in the women with recent pregnancies, although that wasn't a significant difference. And the 5-year tumor-specific survival was 99.5% in both groups, so no different. So in contrast to those 2 Italian studies, these data look a bit more reassuring, although they were done, the analysis was a little bit different. So if women opt to have a thyroid biopsy in pregnancy, the pregnancy itself doesn't really alter anything you do. If it's read as benign, if it's not cancer, we follow the same way we would outside the pregnancy setting. For women who opt to have thyroid biopsies during pregnancy, where it's read as an indeterminate lesion, so atypia of uncertain significance or follicular lesion of uncertain significance is the jargon. These are those nodules where they can't tell just by looking at the cells whether it's cancer or not. And overall, there's about a 10 to 40% likelihood that these wind up being cancer. So most of these women will not have cancer. And so in most cases, it's reasonable if women are going to have surgery for these to wait until after pregnancy is complete, unless there's something unusually suspicious about the ultrasound findings. Outside the pregnancy setting, sometimes for these nodules where they can't tell just by looking at the pathology if they're cancer or not, we do genetic testing, look at molecular markers that give us a little bit more insight about whether it's likely to be cancer or not. But that's not recommended in the pregnancy setting because these molecular tests have not been validated in pregnant women. And it's certainly possible that pregnancy itself might turn on or off different genes in these thyroid nodules and make the data from these molecular marker tests unhelpful. So we would recommend that for women who have a biopsy in pregnancy where they get these sort of in-between results, typically probably wait till after pregnancy and repeat a biopsy, getting the testing at that point when it makes more sense and we know we can interpret the numbers. And then when papillary cancer is diagnosed in pregnancy, again, because surgery is probably safer if deferred till after pregnancy, in most cases, it is reasonable to just follow this if it's diagnosed in early pregnancy, but to follow it with some ultrasound so that if there's substantial growth or if it looks like there's anything particularly concerning, like a tumor that would be extending outside the thyroid or appearance of lymph node metastases, then the surgery could be done in the second trimester. But in most patients where this is diagnosed, the recommendation actually would be to just monitor closely, but to defer surgery till after pregnancy is complete. And in those women who are waiting for after pregnancy to have their surgery, perhaps it makes sense to give a little thyroid hormone. These, of course, are women who still have their thyroids in place and don't necessarily need thyroid hormone replacement, but just with the idea that in general, in people with thyroid cancer, we often like to keep the TSH level a little bit lower, which means the thyroid hormone level a little bit higher to reduce stimulation by that thyroid stimulating hormone and decrease the likelihood of tumor growth. So if the TSH is greater than 2 in these patients, it's probably reasonable to start some thyroid hormone just to keep the thyroid hormone solidly normal. So now sort of turning our attention to what probably may be more relevant for many of you in this session, which is how we think differently about management of thyroid cancer in patients who are pregnant when the cancer is already known. And the first thing to comment on is that most people who've had a thyroid cancer diagnosis and treatment will have initially had either a total thyroidectomy or a thyroid lobectomy. So some or all of their thyroid removed. So most people who are following long-term for thyroid cancer diagnoses have no thyroid hormone that they produce themselves and are getting it through thyroid hormone replacement with medication. People with thyroid lobectomy have half the thyroid in place. Not everybody needs thyroid hormone replacement in that setting, but pregnancy is a stress test for the thyroid. Normally, when the thyroid is in place, it is making up to about 50% more thyroid hormone under the influence of pregnancy hormones. And that thyroid hormone is very important for the health of the pregnancy and for the brain development of the fetus. So in women without a thyroid who can't increase their thyroid hormone production themselves, we have to do it for them by increasing thyroid hormone dosing. Women who've had just a thyroid lobe removed who are not on thyroid hormone replacement, again, because pregnancy is kind of a stress test for the thyroid, sometimes even if half of a thyroid is enough to sort of compensate, make enough thyroid hormone outside the pregnancy setting, may not be able to keep up with the demands of pregnancy and make enough thyroid hormone when a woman is pregnant. So really, patients who are on thyroid hormone replacement, it's important that care providers are letting people know that they're going to need more thyroid hormone when they're pregnant. I usually tell my patients if they ever become pregnant, it's okay to tell their partner first, but their endocrinologist really should get the second phone call because we'll increase the dose of thyroid hormone as soon as we know somebody's pregnant and then monitor very closely. One way to increase that dose appropriately is if you typically take 1 pill once a day to increase by 2 pills a week, which is about that 25 to 30% dose increase. And something else that's really different in pregnancy than outside the pregnancy setting is what thyroid hormones are used. And outside of pregnancy, some patients prefer to be on thyroid hormone replacement that's not just levothyroxine, that's T4. but T4 and T3, the other form of thyroid hormone, so either taking a combination of T3 and T4 pills or taking desiccated thyroid, which contains both T3 and T4. And in pregnancy, that's not recommended either by the ATA or the American College of Obstetricians and Gynecologists. And the reason for that is because the fetus sees T4, but the fetus and especially the fetal brain does not see T3. So if we treat a pregnant woman with a combination of the hormones, she may have normal thyroid function, but we may be making the fetus effectively hypothyroid, have too little thyroid hormone. And because of the importance of thyroid hormone for fetal brain development, there's a concern that there is the potential for sort of irreversible damage. So the recommendation typically is that for women on any kind of combination therapy of pregnancy is desired to typically change people just to levothyroxine alone during the preconception period while they're trying to get pregnant during pregnancy. And then it's fine to switch back after gestation. It's perfectly safe to be on combination therapy during lactation. Goals for TSH are the same in pregnancy as outside. So for people with higher risk thyroid cancers where we're trying to suppress growth of tumor, we often essentially intentionally over replace thyroid hormone a bit with a goal to decrease that TSH to below the normal levels to decrease stimulation of tumor. And we think it's fine to do that in pregnancy because we have data like this large cohort study where they looked at 24,000 pregnant women and looked at the effects of subclinical hyperthyroidism, which is effectively slightly over replaced thyroid hormone, on pregnancy outcomes, and saw that really doesn't seem to be damaging to mother or baby. So safe to maintain, slightly higher than normal replacement doses for thyroid hormone in pregnancy if that's what's desired outside the pregnancy setting for the TSH goals. And then in terms of how closely we need to follow, looking for tumor growth or tumor recurrence in pregnant women who've had a history of differentiated thyroid cancer. This is a really useful study. These are data from Memorial Sloan Kettering, where they looked at 235 women who had term pregnancies after initially being treated for the differentiated thyroid cancer somewhere between 1997 and 2015. And all of these women had blood thyroglobulin levels, so our primary blood tumor marker, measured before and after the pregnancies. And they were all followed with ultrasound as well, before and after pregnancy. You can see in the graph that most of the women had thyroglobulin levels that didn't change with pregnancy, although a few of them had levels that went up. And it turns out that the American Thyroid Association guidelines, sort of rules for how we classify the response to thyroid cancer therapy, work really well for classifying risk in pregnancy as well as outside pregnancy. So women with the so-called excellent response to therapy, that's women where the thyroglobulin is low or undetectable and there's no evidence of any tumor on any imaging. Those women typically did not have any increase in thyroglobulin levels in pregnancy. A minority of them did, but none of them had clinically significant disease progression with pregnancies. Women with indeterminate or biochemical incomplete responses, so women where there's maybe a little bit of thyroglobulin around, but no evidence of disease that can be seen on imaging. Some of those women, a minority of those women, had a bit of an increase in the blood thyroglobulin levels during the course of pregnancy, but most did not, and none of them had clinically significant disease progression. But of the 38 women who had known tumors that was still visible on imaging before pregnancy, more of them, about a third of them, had elevations in thyroglobulin as pregnancy progressed. And 8% of them had growth of tumor that was clinically significant, that led to a need for additional therapy. And another 21% of them had sort of some growth, but that didn't actually change any clinical outcomes. So it sort of looks like the only group that's really at significant risk for tumor progression, specifically probably due to pregnancy, is that women where we know there's some residual tumor and we can watch it. And very recently, just this summer, we had a paper published from China where they followed 124 women aged 16 to 35 who'd had both surgery and radioactive iodine treatment for differentiated thyroid cancers with metastases to their lungs. So these women were all treated between 2008 and 2018. Of those 124 women, 37 became pregnant after their treatment. And all of these women had the progression of their thyroid cancer in their lungs measured with serial CT scans. And what they saw, again, some data I think are very reassuring, that even in this group with this known structural disease, with known metastatic disease in their lungs, there was no difference in progression-free survival or overall survival over the course of follow-up in this study in the women who became pregnant and the women who did not. The things that predicted women who did not do well were the same predictors as outside pregnancy. So women with thyroid cancers that were known not to take up radioactive iodine, or women who needed multiple surgeries for tumor resection. But pregnancy itself did not seem to cause worsening of disease. And so for those reasons, women who have sort of achieved the so-called excellent response to therapy based on ATA guidelines, we don't really need to monitor any differently in pregnancy than we do outside. So whatever ultrasound or thyroglobulin monitoring, often just a thyroglobulin once a year that we do outside the pregnancy setting is what we do inside pregnancy. But women with, the potential for persistent disease, it's recommended that we follow a bit more closely. So probably follow blood test thyroglobulins a little more frequently in the pregnancy setting, and also follow ultrasound or other imaging a little more frequently in the pregnancy setting, just to make sure that if there is some tumor progression, that it's caught pretty early. Women with advanced thyroid cancers, sometimes treated with the tyrosine kinase inhibitors. This is really only for those patients with advanced cancers, progressive disease that hasn't been responsive to other measures. And there are no kinase inhibitors that are available, and probably there won't be because of how those drugs work, that are necessarily completely safe in pregnancy. So all of the ones that are currently approved for thyroid cancer are considered FDA pregnancy category D. So there is evidence that they may cause fetal harm, may cause birth defects. And so use in pregnancy would be very careful, knowing that potential benefits might outweigh risks for women for whom there may be no other effective therapies. And because it's not known whether these drugs are transferred into breast milk, but there'd be concerns about potential adverse effects on the breastfed infants, it's advised, pregnancy would be sort of a very careful decision about sort of balancing risk and benefit, but it's not recommended to use them during breastfeeding. Just a couple studies I want to show you related to the effects of radioactive iodine on subsequent pregnancy outcomes or subsequent fertility. So two papers, both very recent. This one was published in the journal Thyroid earlier this year. And this was a systematic review and meta-analysis of 22 studies. So basically looked at the world literature, assessing the effect of radioactive iodine on ovarian function and fertility in women with thyroid cancer. And what they found in this review of the literature is that up to about a third of women in the first year after receiving radioactive iodine treatment for thyroid cancer will have some irregularities of the menstrual cycle. Sometimes they're absent for a while or they just become irregular. On average, that was in about 12% of women, but again, the study with the highest level of this menstrual irregularity was 31%. And probably those irregular periods are a marker for decreased fertility in that year, because probably they're a marker for irregular ovulation. They also noted that women who'd had radioactive iodine treatment had menopause slightly younger than women who had not had radioactive iodine treatment. Not hugely younger, but it was 49.5 years on average compared to 51 years. So there may be a slight effect on fertility, and I think this is something that ideally would be discussed in making decisions about having radioactive iodine treatment in the first place, and something to be aware of. Reassuringly though, when they did sort of a formal meta-analysis, meaning they pooled the data from 4 of these studies and did sort of an analysis with the combined groups of patients, which gives a little bit more statistical power to see small effects. They looked at the likelihood of just people becoming pregnant after radioactive iodine compared to people who had not had radioactive iodine for their thyroid cancers, and found no difference. So although there's a signal that perhaps there's a slight decrease in fertility and slightly earlier menopause in women who've had radioactive iodine treatment, Overall, there doesn't really seem to be a big difference in women becoming pregnant. And then a very large study, this one from South Korea, published a couple of years ago, looked at women aged 20 to 49 in a big national database. This is 111,000 women. All of them underwent thyroidectomy, so thyroid removal, for the treatment of differentiated cancers between 2008 and 2015. About half of these women were treated just with surgery, and the other half had surgery followed by radioactive iodine. And they looked at adverse pregnancy outcomes in the women who got surgery alone versus the women who got surgery with radioactive iodine, and really didn't see a whole lot of differences. So risk for preterm delivery, the number of pregnancies women had, birth defects, particularly of all the different organ systems that they looked at, miscarriage or abortion, none of these outcomes were different in the radioactive iodine treated women compared to the women who didn't get radioactive iodine. And then they honed down a little bit more on the women who got the radioactive iodine, and they looked to see, did having a higher dose of radioactive iodine increase the risk of adverse pregnancy outcomes? Or did the interval, the time length between having the radioactive iodine and becoming pregnant make a difference? And here, the radioactive iodine dose didn't seem to affect pregnancy outcomes at all, which I think is, again, reassuring. But the time that women waited to become pregnant after the radioactive iodine did seem to make a difference. So there was a higher risk for these adverse pregnancy outcomes and for birth defects in children if women became pregnant in the first 5 months after that radioactive iodine treatment compared to if they waited longer than 6 months. But reassuringly, waiting longer than 6 months, if women did wait longer than 6 months after that treatment, there didn't seem to be any downstream adverse effects. And one last note about radioactive iodine is that we don't give radioactive iodine in women who are breastfeeding, because the lactating breast actively concentrates iodine in breast milk. And presumably nature does this to allow the breastfed baby to have adequate iodine nutrition. But when we're talking about radioactive iodine, we really don't want that concentrated in breast milk, and we don't want to be feeding that to infants. So we do not give radioactive iodine during breastfeeding. And it's actually also important to know that you need to wait 6 weeks to, at least 6 weeks to ideally about 3 months after stopping breastfeeding. So after the baby is completely weaned, before giving radioactive iodine, because those changes that allow the iodine to be concentrated in breast milk take a while to resolve. And even though a woman who's already weaned her child, the baby's not going to be at risk from the radioactive iodine in the breast milk directly, because there are still those changes in the breast might be at risk for damage from radiation. So again, waiting at least 6 weeks after stopping breastfeeding before getting radioactive iodine, just for safety for both mother and baby. So finally, there's unfortunately not a lot to say about medullary and anaplastic cancer in pregnancy. Anaplastic cancer is usually a cancer of older individuals, so it doesn't occur very often in people young enough to become pregnant. Medullary cancer is a rare enough cancer, and then pregnancy is a rare enough sort of intersection with medullary cancer that there's just not a whole lot of data in the literature. So we don't have any big or even really small case series. We have some sort of case reports in the literature, and not much data to know what might be different in those women. But what is sort of just, I think, common sense and not based on a lot of data, and what does show up in the pregnancy guidelines from the American Thyroid Association, is that certainly when these cancers are newly diagnosed in pregnancy, by and large, these are not cancers where we want to wait for surgery, because surgery, certainly for medullary cancer, may be the best chance at cure. And so when medullary or anaplastic cancer occur during pregnancy, this would be the exception, where we wouldn't typically want to wait until after delivery to recommend surgery. So I'd sort of conclude by noting that nodules and thyroid cancer are pretty common in women of childbearing age, and it's not that infrequent for thyroid cancers to be diagnosed for the first time in pregnancy, or for women with a history of thyroid cancer to go on and become pregnant. It's perfectly safe to do that. So there should not be, thyroid cancer in general should not be a reason not to become pregnant. That we don't change our goals for thyroid hormone levels in pregnancy, but we need higher amounts of thyroid hormone typically to get women to goal in pregnancy. So really important for women who are on thyroid hormone replacement to know to alert caregivers and to increase dose as soon as that pregnancy occurs. Although overall pregnancy seems to be quite safe in women with differentiated thyroid cancer, a minority of women with known persistent tumor where we can see disease, it's structural, that's visible on imaging, there may be some progression during pregnancy, probably driven by pregnancy hormones. And so those women do need slightly closer monitoring during gestation. And then finally, radioactive iodine therapy probably does not substantially impair fertility, although there might be subtle effects. And it doesn't seem to impact pregnancy outcomes as long as pregnancy is deferred for at least 6 months after the radioactive iodine administration. So with that, I'm going to stop sharing my screen here. Thank you for your attention, and let me see what you've got here for me in questions. So one question says, is it better or easier on the body for somebody who's pregnant who needs that 25–30% increase in thyroid hormone to take a steady increased dose every other day rather than increasing the dose, doubling the dose 2 days a week? And the answer is probably not. The half-life of levothyroxine is really long, so levels in the blood become really stable. And taking an extra pill, a couple days a week, the levels of thyroid hormone in the blood actually don't really shift a whole lot on those days. So safe in and outside pregnancy to do it that way. And I think it's sort of a matter of preference. So for some people, just remembering what day is it? Did I take my thyroid hormone? Did I take my extra dose? What day of the week is it? Is hard to do. And in that case, it's easier just to go up, 25–30% on the daily dose. But there's no safety reason to do it one way or the other. And let me see what else we've got here. So somebody whose daughter had differentiated thyroid cancer, had total thyroidectomy and radioactive iodine in 2016, getting followed up, had one small lymph node metastasis, and the doctor confirmed that she could get pregnant, and she's now 4 months pregnant, her fourth child, age 41. Would appreciate any thoughts. So I would say, good for her. I think she is safe. Congratulations on your impending grandchild. I do think it's safe in pregnancy, and with that known small lymph node, would probably just monitor that a little bit more closely in pregnancy with ultrasound. But I don't think, all the data I shared with you, we don't have huge studies, but everything we've got really sort of suggests that it's not unsafe to be pregnant with thyroid cancer, and that I don't think that the amount of disease she has is concerning. Just, for everybody's reassurance, would probably do a little bit more surveillance with ultrasound. And then, a very good question here. What's the recommended frequency of TSH testing in the course of pregnancy during nursing? And points out that the context here is a patient who is treated with lobectomy for a low-risk papillary cancer, and currently taking low-dose thyroid hormone. So I think actually a lot of pieces of this question. Let me sort of walk through this. So the first piece of this is that the hormones that drive change in thyroid hormone in pregnancy, really those changes start about week 7 of gestation, and then everything kind of stabilizes by about week 16. So this tends to be sort of dynamic, and things are shifting, and we tend to have to make frequent adjustments if we're going to between those weeks 7 and 16, and then things kind of stabilize. So it's recommended that we typically get TSH testing to make sure that thyroid hormone dose is adequate every 4 weeks of pregnancy until week 16. And the goal is going to be your same goal in the thyroid cancer setting as for TSH as it would be outside the thyroid cancer setting. So every 4 weeks till week 16. And then since things tend to stabilize at that point and dose requirements don't tend to shift a whole lot, we recommend checking once more kind of late 2nd or early 3rd trimester, just to make sure things are still at goal. And then if they're stable, sort of continue that dose until delivery. As soon as the baby's born, thyroid hormone requirements pretty much go right back to where they were before the pregnancy. So once the baby is delivered, it's fine to go right back to the pre-pregnancy dose of thyroid hormone. During breastfeeding, a little bit of thyroid hormone gets into breast milk, but truly tiny, tiny, tiny quantities, not really enough to bump the baby's thyroid hormone levels. Breastfed babies of mothers who are taking thyroid hormone don't need any thyroid hormone monitoring or special testing. And we don't need to test women specifically due to the breastfeeding, which doesn't, unlike pregnancy, which causes big shifts in thyroid hormone production and thyroid hormone requirements, breastfeeding really does not. But often we want to be checking a TSH level about 6 weeks after delivery, just to make sure that that pre-pregnancy dose that women were on is still the right dose for them after pregnancy. Sometimes, you know, in somebody who still has some thyroid tissue, like somebody with a lobectomy, there can be a progressive decline in the thyroid function over pregnancy, and you want to make sure that that dosing is still appropriate. So again, typically back to the pre-pregnancy dose at delivery, check levels at 6 weeks and adjust if needed at that point. And then we have another question. It says, for a 35-year-old woman who had a thyroid cancer 2 years ago with radioactive iodine and surgery, is it better to wait to have more years cancer-free or to start trying to conceive sooner rather than later due to age? And I would say, if you want to get pregnant, there is no reason to delay. It's not, once you have waited that 6 months after the radioactive iodine, there's really no evidence that the thyroid cancer treatment impacts the pregnancies later on than that. And by and large, probably say at your age 35, probably a good idea to start trying to conceive, because likelihood of conception does start to decline at about that age. So I would say that the answer there, probably no reason to delay. And if you want to get, start trying to get pregnant, do that. And really the answer would be, that's, I think, the case, as of 6 months after the radioactive iodine treatment, from all the information we have. And is the recommended TSH goal during pregnancy for low risk papillary thyroid cancer patients, so after surgery, not on suppressive therapy, the same as outside pregnancy? Yes, it is. So in pregnancy, women who are hypothyroid, not because of thyroid cancer treatment, but just in general, the recommendation is that we treat for a TSH goal of a TSH less than 2.5. Again, because of the importance of thyroid hormone for the fetal brain development, we always want to make sure we're getting enough thyroid hormone to pregnant women. And so that's sort of keeping it at sort of the higher end of normal, which would be that TSH lower than 2.5. But typically we're doing that anyway in women who've had a history of thyroid cancer. So typically for a low risk thyroid cancer, our goal TSH is less than 2. And I would use that target for a woman with thyroid cancer in pregnancy. Again, use those same targets, whether it's less than 2, whether it's a TSH in the range of 0.1 to 0.5, whether it's that TSH that's less than 0.1, the same target that's appropriate outside pregnancy is going to be appropriate and safe in the pregnancy setting. And one thing with the last question, I realized I forgot to really talk as much about the lobectomy. So women who've had lobectomy for treatment of lower risk thyroid cancers may or may not need thyroid hormone replacement. So some are going to be on thyroid hormone, some will not. And for women who are not, I said, again, the pregnancy being a stress test for the thyroid, that's a time when, even if outside the pregnancy setting, that thyroid lobe is enough thyroid tissue to make enough thyroid hormone, it may not be in gestation. So I would recommend the same frequency of TSH testing in pregnancy. I don't think you necessarily need to start thyroid hormone without any testing just because you're pregnant, but those would be women who should be monitored with those TSHs every 4 weeks and up until week 16, to just make sure that if that half of a thyroid turns out to be not quite enough to meet the demands of pregnancy, that we can start some thyroid hormone quickly and make sure that both mother and baby are getting enough. All right. Any research regarding external beam radiation in pregnancy or hypoparathyroidism in pregnancy? So external beam radiation pregnancy, probably by and large, we don't like to give pregnant women a lot of exposure to radiation. I guess it would depend very much on the circumstances and how well the baby could be shielded. So it might depend a little bit on location of where that external beam therapy was happening. I would say, though, that probably, unless there's a very compelling reason to do it, it would probably not be a good idea in pregnancy, but there could be circumstances and locations for tumor where that might be appropriate. Hypoparathyroidism in pregnancy is tough. So it's challenging to manage. Pregnancy changes normally blood calcium levels and hormonal regulation of blood calcium levels. And so for women who've had thyroid surgeries that have destroyed the parathyroid glands, usually we have them on lifelong, activated vitamin D and calcium supplementation to keep blood calcium levels normal. And that requires very close monitoring in pregnancy because it's very easy for that to get out of whack. So that is a challenging situation. I don't think we have big studies showing the right way to manage. We just know that it's tricky and requires close monitoring. And let's see. So for some women, T3 supplementation makes all the difference in keeping TSH levels suppressed to prevent recurrence of papillary cancer, and that T4 alone is not successful. I did mention that T3 supplementation alone, or T3 supplementation really of any kind, is not recommended during pregnancy. Any research weighing the risk of T3 during pregnancy on the fetus versus the risk of discontinuing T3 and losing that TSH suppression. There are no trials for that. I don't think there would be trials for that because I think there would be enough concern about risk to fetus of doing such a trial that probably would not be ethical. Mostly what we know about this comes from animal studies, where they know in mouse models, when the pregnant mouse has a thyroid removed, so there's no thyroid, they give back T3, they give back T4, they give back combinations. What is clear is that the fetus really doesn't see the mom's T4. So the fetus really only sees the T3 that comes across the placenta, particularly in the fetal brain, where it's so important for the brain development. And so I would say probably if it's been challenging to get the TSH, suppression to goal with T4 alone, I wouldn't want to be making the best time to make these changes is not in pregnancy when you're worried about things getting out of control and what people becoming hypothyroidist. So I think the best time to try and address this would be preconception. And probably just giving a whole lot of T4 because we're not really so concerned. When the mother's getting the T4, the baby sees the T4. So we wouldn't be concerned about inducing fetal hypothyroidism. So that's a situation that I think might be challenging, might need close monitoring and a lot of careful conversations pre-conception. But I think the best way to do that really would be to radically increase the T4 dose pre-conception, get a woman stable on that dose prior to her attempting conception, and then increasing that T4 even more. And this might require really massive T4 doses once she's pregnant, but with close monitoring of the TSH, that would not be unsafe for the fetus. And I think that would be less unsafe for the fetus just because of the uncertainty about the T3 the fetus would see of continuing that T3, T4 combination therapy. How often would I recommend testing for pregnancy when trying to conceive? So the home pregnancy tests these days are pretty sensitive. They're pretty good. They can pick up a pregnancy within a few days after a missed period. And so typically I would suggest just that, testing a few days after a missed period. And if still no period after another couple of days, test again. But those tests are pretty good. And generally a good idea to be, if you're trying to conceive and particularly for unthyroid hormone and some of these changes in dose are likely to sort of come into play as soon as you're pregnant. Good idea to do that home pregnancy testing so as soon as you're pregnant and you can make those dose adjustments as soon as possible. And post-pregnancy, let me see if I'm understanding this. How do mothers know the ripple effect of thyroid cancer or wrong dosage may have had on the baby? There's no way to know that. There's really no way in any pregnancy really to know what exposures might or might not have impacted the fetus. That's true for any pregnant women. I think women with sort of chronic health conditions like thyroid cancer that's been managed may worry more about this. But I think what is reassuring are the kinds of studies I just showed where they've compared women who did and didn't get radioactive iodine, women who did or didn't get diagnosed with thyroid cancer in pregnancy, and really not seeing a whole lot of difference. So I think from the information we have right now, it does not appear that pregnancy itself is particularly harmful or particularly dangerous. And thyroid hormone replacement, we know from not just in the thyroid cancer setting, but just the hypothyroidism setting, very common condition in pregnancy. We definitely know that thyroid hormone, when dosed appropriately, is safe for pregnancy. You know, if the thyroid hormone level gets out of whack in gestation, is there ever any way to know downstream if there was an effect in the baby's brain development? Probably not, again, but that's true, as I said, for any pregnancy, that you never really know what effects for good or for bad other exposures have as well. So let me jump over to the chat. I think I got to the bottom. Lois, help me if I missed anything. I think I got to the bottom of the
I think
list.
that you have done an excellent job of getting through all of our questions. The chat area, I do not believe there were
Nothing
any
else.
questions in the chat area. So Dr. Pearce, thank you so much for just sharing, giving us the overview and sharing such a great presentation with us with great numbers and just documentation that we can kind of hang on to once we leave. And I have just a final question for you before we wrap everything up. Being a facilitator for ThyCa and down through the years, it's been since 2004 that I've been involved in the organization. And as a facilitator, I've had young women come to our group sessions, and some have just found out that they're pregnant, and at the same time, just found out that they also have thyroid cancer. And I think one of the areas that if you could just share a little bit with us about what your organization, or as a best practice for medical professionals, what would be the next step to really help this young person, young women who are pregnant, to handle the emotional part of this process?
So that's a great question, and one without, I think, a simple answer, because I think there are a lot of pieces to this. So one piece is the same as for any time that I have to tell somebody they have a new thyroid cancer diagnosis, is just to reassure that, you know, this is a stepwise process, that there are treatments that are available, that will sort of walk through them, you know, walk through all the treatments with them, that and sort of be there to be available to answer questions. So I think, you know, usually when you give that diagnosis of cancer, people's brain, that's all they can cope with, and don't hear anything else. So being available and just, you know, having ongoing conversations, I think, is helpful, because people sort of think of questions often after the fact. I think referral to groups like ThyCa, hugely, hugely helpful. Other women in these groups who've had this experience and can provide some reassurance and some emotional support. And then I think, you know, for where appropriate, if people are really anxious, and these are anxiety producing situations when both of these things are happening simultaneously, I think often referral to my colleagues who do, you know, mental health therapy is appropriate to just provide some additional support in a setting that can be incredibly stressful.
Thank you so very much. And we are, again, want to, as on behalf of ThyCa and all of the attendees, we appreciate your presentation, your caring of all the questions that we had in our Q&A. And I believe at the very end here, someone is summing it up for us here. Thank you so much for your presentation and your time in answering questions. I am 36, recently treated with PTC, and trying to, I believe she wanted to say conceive a child, hopefully. This was incredibly helpful. Doctors like you make such a difference in our lives. I couldn't say it any better, Dr. Pearce.
Lovely. So thank you so much. My pleasure to be with all of you today.
And enjoy the rest of the conference. Thanks again, Dr. Pearce. And our producer in the background back there, thank you so much. Bye-bye.
Bye-bye.